Hello, everyone. I apologize for the delay. My name is Megan Glenn. I'm the National Assistant Director of Programs at the American Liver Foundation, and I would like to welcome you to today's webinar. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice for patients with liver disease and their families through education, support, research, and advocacy. Today, we are pleased to partner with the University of Pittsburgh Medical Center on this webinar to discuss the complex conditions that may lead to a need for a liver transplant, promote living organ donation awareness, and provide valuable information and resources about living organ donation. I would like to thank Dr. Abby Humar, who will be sharing his expertise on today's webinar. Dr. Humar is a world-renowned transplant surgeon. As Chief of Transplantation at UPMC, he oversees all clinical and clinical research activities as one of the world's most active and prestigious transplant programs. Dr. Humar's areas of interest include partial liver transplants, including live donor liver transplants, and studies of hepatic regeneration, tolerance protocols, clinical outcome studies in kidney, liver, and pancreas transplants, and outcomes in pediatric kidney transplants. Dr. Humar has had more than 600 abstracts accepted at national and international transplant meetings. In addition, he has authored or co-authored more than 180 manuscripts, 25 book chapters, and 3 books. I would also like to thank Tony Scrow, who will be sharing his experience of receiving a living donor transplantation from his daughter. Now, let me just start with a few housekeeping items. On the upper right-hand part of your screen, you should see a dialog box. If you don't see it, there's an orange arrow that you can use to expand the window. From here, you can ask questions at any time, and we'll be answering them in the last 10 to 15 minutes of the webinar. We will get as many questions answered as possible, and whichever questions we don't answer, we will get them answered at a later date. We welcome your participation, so please do send questions in. At this point, I will turn the slides over to Dr. Humar, who will now present on living organ transplantation.
All right. Well, thank you very much for the opportunity to come here and talk. And I know we have a little bit of a mixed audience of patients, maybe patients' families, and maybe some healthcare workers that look after patients with liver disease. So I'll try to keep it fairly broad and general and not so medically orientated, so that everyone can chime in. So let's just start with a brief overview of the liver. As you know, I think of the liver really as our big chemical factory. It has over 500 different functions, and any one of those functions lost can lead to failure of the liver. It's also one of the few organs that we have that will actually regenerate, and it's actually one of the very unique organs that can do that. As you know, liver disease is very common worldwide, and it's certainly very common in the U.S. There are 30 million plus people that have liver disease. And one of the unique things about liver disease is that it's a direct risk factor for developing liver cancer. It's the main risk factor, in fact, for developing a liver cancer, which is one of the few cancers that are actually increasing in frequency as opposed to decreasing as compared to many of the other cancers. But liver disease is very common with over 30 million people. There are lots of different causes for liver disease, everything from hepatitis B and C, alcohol, but more and more now we're seeing patients with NASH, which stands for non-alcoholic steatohepatitis, but it's a form of fatty liver disease that can ultimately lead to cirrhosis. And that is the way that many of these diseases present, is that they lead to scarring in the liver, which is called cirrhosis. And so therefore, once patients reach that stage, it doesn't really matter what has caused the liver disease. It pretty much all behaves in a very similar fashion. So let's talk about liver transplantation, which really represents, to me, one of the miracles of modern medicine, and it probably is the only curative method we have for treating someone who has end-stage liver disease, meaning that they've progressed to the stage where the liver really is not working, it's failed. The only way that we have, unfortunately, to treat them at the present time is a liver transplant. And liver transplant actually is very good with great results. We now, most places have outcomes of better than 90% survival at a year out from transplant. And as I said, it has become, in a very short period of time, just about 30-some years, it's become the gold standard way that you would treat someone with liver disease. So let's fast forward to what the current status of liver transplant is in the United States today. And if you look at this, there's some important data points. So there are about 14,000 people waiting for a liver transplant in the United States. So those are the people on the waiting list. And we do roughly about 8,000 transplants a year. And so right away you can see that there are not enough transplants for all the people that need a transplant. So it's not necessarily a situation where you need a transplant, you get a transplant. And that's because there are a lot more people that need a transplant than are organs available. And that creates this unique situation of a waiting list and having to allocate a scarce resource. So essentially you're having to ration the number of livers available because there's not enough livers for all of the people that need them. So that creates really this waiting list and a couple of unique consequences of that waiting list. So what it means today in the United States is that if you're on a waiting list waiting for a liver transplant, depending on what area you're in and your blood type and things like that, but there's probably about a 15 to 25% chance that you're never going to get to that transplant. And that's just a nice way to say that you will die from your liver disease before you get to the top of the waiting list. And that's just one of the harsh realities of liver transplantation today. But even for those other people who are fortunate enough to get a transplant, because it's a limited resource, there's a waiting line, there's a queue essentially, and you have to get to the top of that queue to get the transplant. Well, while you're waiting to get to the top of the queue, unfortunately, your liver disease is not waiting. It continues to progress. And the way you get to the top of that waiting list is really by being the sickest person. So what that really means is by the time someone gets to a transplant, they're sick, and that usually leads to a longer and a more difficult recovery, as you can imagine, undergoing a major operation when you're sick as opposed to going through it when you're relatively healthier. The third important thing that often people don't talk about is that not all the patients that could benefit from a liver transplant are actually listed for a transplant or offered a transplant. I equate it to the situation where you have a sinking ship with 1,000 people, but unfortunately only 500 life jackets. Everyone on that ship can benefit from having a life jacket, but there's only 500, and we have to decide who are the 500 that are going to get it. And therefore, there's no point putting all of those patients on the waiting list. All that does is increases the size of the waiting list, doesn't increase the number of transplants that are being done because that number is relatively fixed. And this is our own data from our own center, and on the curve on the graph on the left, what you see is the median waiting time. So that's how long someone waits on our waiting list before they get a transplant. You can see that someone's waiting roughly about 2 years now before they can get a transplant in many situations. And the curve on the right just shows you how sick a patient is. It's a measurement called the MEL score, which many of you may be familiar with, but it just gives you an idea as to the severity of illness, how sick someone is from their liver disease. And that's been steadily increasing. So we're transplanting sicker patients and they're having to wait longer. And as I said, we have a waitlist mortality of about 25% in our area. So that means when I put a patient on my waiting list, there's about a 25% chance that they will never get a transplant, that they will die from their liver disease before they do. So a possible solution to all of these consequences is a living donor liver transplant. And what exactly is a living donor liver transplant? Well, a living donor liver transplant is where we take a part of the liver from an otherwise healthy individual and transplant it into the person who needs the transplant. And the reason we can do this with the liver is because of two unique properties. We have a lot of extra capacity built into our liver. So to do all of the functions of the liver, we don't actually need the whole liver. We could get by with probably only about a third or even less of that liver, and the liver still does everything that it needs to do. And two, the liver is one of the few organs that, as I said, that we have that will actually regenerate. And so this ability to regenerate and this extra capacity that we have built in makes for the possibility of a living donor transplant. And there are a lot of advantages to a living donor transplant, and then there's some disadvantages. As with every medical therapy that we have available, whether it's a drug or whether it's a surgical procedure, you have to weigh the advantages with the disadvantages. What are the disadvantages of this procedure? Well, this is a very unique situation in medicine in that we're actually operating on a person who doesn't need an operation, and that's the person who's the donor. This is the individual who's donating part of their liver to help someone else, but obviously they're not going to get any medical benefit from it. And so we have to know what the risks are to the donor, both in the short term as well as the long term, because remember, these are healthy individuals that are donating, and the expectation is that they're going to have a long, full life. And so we have to really balance very carefully the risks to the donor against what the advantages are. And the advantages, I think, anyways, are significant with a live donor transplant. So obviously, if you were going to be one of those individuals that were never going to get a transplant, if you were part of that 25% waitlist mortality, and you have the option of a living donor, right away it's a life-saving procedure. And therefore, you can minimize your risk of dying from liver disease if there's the possibility of a living donor available. But also beyond that, you can decrease the waiting time, because now it's no longer you have to wait to be the sickest person. If you have a donor that's your family member or friend that wants to be your donor, you can have the transplant as soon as you're ill enough to need a transplant, as opposed to being at the top of the list. And therefore, we can transplant patients before they become critically ill, which leads to usually a smoother operation and a smoother recovery. It can be a planned operation, which is important because we can fix conditions and we can tune patients so that they're in the best possible shape that they can be in before they get their transplant. There's some other advantages also. There's minimal period of time that liver is out of the body, so it's fresh, so to speak. There's some immunologic advantage, meaning that the risk of rejection is probably less if you get it from a living donor. There's some financial benefit because there's less resources being used as a whole. And then it adds to the pool of organs being available. So for every one individual that has a living donor available, that's one individual that doesn't need a liver from the deceased donor pool, and that frees up an organ for someone who doesn't have the option of a living donor. So those are all the advantages, and as I said, there are a significant number of them. So if there are so many advantages, why aren't many transplants being done? And there aren't very many transplants being done in the U.S. because if you look in all of 2018, there were only about 400 live donor liver transplants performed in the entire country. That represents less than 5% of the total number of liver transplants that were done. So it's a very small percentage of the total number of transplants that are being done in the United States. And in fact, if you compare the United States to other places around the world, you can see that live donor liver transplant in the U.S. makes up a very small percentage of the total number of transplants. And certainly in places such as the Far East, the Middle East, Asia, those places, living donor liver transplant is actually the most common way that a person receives a transplant as opposed to the minority of patients. There are very few centers in the U.S. that really do or offer live donor liver transplant. If you look at the entire history, there's only 15 centers total in the United States that have done more than 100 in their entire history. And if you look at the 2018 data, there were only 12 centers in the U.S. that did more than 10 live donor liver transplants in a year, which is not a very big number, which just means that there are not a lot of programs that are offering this to their patients. So why have the number of live donor liver transplants remained so low in the United States? And there are a lot of reasons for this. We have the option of deceased donor transplants, at least for some patients. It is a complex procedure with requires some technical expertise. You need an entire team dedicated to it, and therefore not all places are able to invest in having that team. There's obviously concern, as I said, in operating on an otherwise healthy individual, the donor, that doesn't need the operation. But in my mind, the main reason why live donor liver transplant numbers are so low in this country is that people just don't know about this option. And by people, I mean the patients and the family that are looking after the patients, the providers. By that I mean the family physicians, the gastroenterologists, the hepatologists maybe that look after these patients don't know or don't know the reality of what living donor liver transplant is about, and then the payers who are then responsible for making sure the patients get the care that they need. I think all of those areas are areas that we can work on in terms of educating. But we certainly believe in live donor transplant. We have strong programs in both our adult and the pediatric side at UPMC. And the key to it is that we've invested in building a very strong team. The team doesn't include just the surgeons. The team includes the surgeons, the medical doctors, the hepatologists, the nurses, the coordinators, the social workers, the financial people, the advocates, and on, all of those people that we have assigned and dedicated for the living donor program here. We're the only center performing live donor liver transplant in Western Pennsylvania, and just to give you an idea, both in 2017 and in 2018, more than 50% of all the transplants that we did here came from a living donor. So contrast that to the national average, which as I said, is less than about 5%. This is just a graph showing the numbers of transplants that we've done, and you can see that especially in the last few years, we really invested heavily in trying to build our program and offer this to more and more of our patients. We're doing roughly about 70 live donor liver transplants a year between our adults and our pediatric patients. This is just the number of transplants done at all the major centers across the country. This is 2017 data, and again, you can see that we certainly embraced this procedure fully and are committed to growing it. So I think if you're a patient thinking about whether this is a good option for you, or if you're a person who's looking after someone and you're thinking of referring them for this, it's a good idea to know what the results are like. That's how you would evaluate any medical therapy. How successful is it before you would consider it as an option? So let's talk a little bit about what the results are like with this procedure. Now remember, when we talk about this procedure, we have to talk about two different patients. We have to talk about the donor and we have to talk about the recipient, and we have to know what the results are like in both of those, both the donors as well as the recipients. So let's start right away with the results in the donor. And as I said, this is an individual that doesn't need an operation, so we have to be sure that we're able to do this with the greatest amount of safety. So if you look at the national data, until the end of January 2019, there were 6,826 live donor liver transplants that had been done. To date, there have been 6 donor deaths in the U.S. over the last 25 years. That's an estimated risk of about 0.1%, and additionally 3 donors that received a transplant themselves because the portion of the liver that was left wasn't adequate for them. So those are the worst possible complications on a national basis. If you look at several surveys that have been done looking at the overall complication rate, it's roughly about 30%, though of those only about 10% are what we would call a major complication, anything that requires some sort of intervention to fix, another surgery or something else. Our own data, knock on wood, we've not had any cases ever of donor deaths or cases of liver failure. Our overall complication rate is about 20%, with roughly under 10% being major complication rate, and that's pretty equivalent to what you would see reported at most major centers. And our mean length of stay for the donors is 5.8 days. Now, beyond that, it's very important to know the data of how quickly these patients are getting back to normal quality of life, because, as I said, these are otherwise healthy individuals. So just as a rough estimate, as I said, they're in hospital for about 5 to 7 days. Most of our donors are back to a desk job within about 4 to 6 weeks, back to a physical job in about 10 to 12 weeks, and most are 80 to 90% back to their normal level of health by 3 months post-donation. And we follow all donors for 2 years after the surgery just to make sure that they've got complete recovery and that if there's any complications, we address those. Now, what about the recipients? What are the results like in the recipient? And let me just explain these curves to you. On the left are survival curves. So this is the probability of survival starting at 100%. And the red represents our living donor liver transplant patients. The blue represents our deceased donor transplant patients. You can see that there's roughly about a 5 to 10% survival advantage We have roughly just over 90% one-year survival in our living donors, and just about mid-80s for our deceased donor patients. But it's overall also the other data that suggests it's a smoother course for the living donors. Roughly about half of our living donor transplant patients don't even get any blood transfusion, which for liver transplant patients is fairly unusual. And the median length of stay you can see is a little bit less if they have a living donor transplant versus a deceased donor transplant, because generally there's a smoother recovery. This is what our results are like compared to other centers, and if you're interested in finding out, you can go to that website, optn.org, and look at just about any program in the country and what their results are like with live donor transplant. I'll just explain the curve. Each of those circles that you see is a program in this country, so that the x-axis represents the volume of that program, the number of transplants that they're doing in that period of time, and the y-axis is the hazard ratio of results. So that just means expressed as a ratio of what their results should be like versus what their results are like. So if your results are exactly where they should be, you're at 1.0. If your results are better than they should be, then you're below that line of 1.0. And if they're worse than they should be, then you're above that line of 1.0. So that's every program in the country. And as I said, if you're interested, you can look up any program. That blue circle is our program, and you can see that we're doing a high volume of transplants, and we have acceptable results with the transplants. But we've seen other benefits. So again, this is data from the same website. This is looking at a center's transplant rate. And a transplant rate is really essentially represents the chances of you getting a transplant at that program. On the left is what our transplant rate, that red arrow, represents back in 2015. And since we've started doing more live donor transplants, you can see that overall transplant rate has increased significantly. And it's better now than are expected because of the number of living donor transplants that we are doing. And again, this is another piece of data from that same website. This is waitlist mortality. This is that risk of dying on the waiting list. And you can see that in 2016 we were at almost 26%, and now closer to 2018 we've decreased that number down to about 24%. And we're hopeful that we'll just continue to decrease that further as we're able to transplant more and more of our patients with living donors. This is how we started thinking about living donor transplants a few years ago, that we would use it to transplant patients who were low on the waiting list, that had a hard time getting a transplant, that had bad prognostic signs, people that were having tumors that were outside of criteria and didn't qualify for a transplant. Or international patients. We didn't want to use a scarce resource for patients coming from outside, and so we exclusively do live donor transplants for those patients. So we started with that group of patients, but we saw that we could get good results in this group, and so we started to expand. And we started to do patients who were sicker, what are called the higher MELD patients. And now we don't use MELD as a restriction. We'll transplant patients regardless of the MELD, as long as they have a good donor, and we can use various strategies to make sure that we can get acceptable outcomes in those patients that are sicker. And then we moved on to patients who didn't qualify for a transplant in the regular way. If we could just move back to 2 slides, one more. Yeah, that one. So these are just some of the indications. We'll transplant patients with tumors that wouldn't necessarily qualify to get a deceased donor transplant, but who nonetheless will benefit from having a transplant. These are patients with diseases such as hilar cholangiocarcinomas, patients who have disease to their liver from somewhere else, like a colorectal cancer, or patients who have tumors in their liver but that don't qualify for a deceased donor transplant. All of these patients we know will get a benefit from a liver transplant but don't qualify, and therefore a living donor transplant is a good option for them. And moving on now to what we call our extended use. So we now offer living donor liver transplant to virtually all patients, and we really feel that this is the first option for all of our patients, whether they have a low MELD score or a high MELD score, if they have acute liver failure or chronic liver failure, if they have tumors such as cholangiocarcinomas or hepatocellular cancers that meet or don't meet criteria. And there are many groups where a living donor transplant actually has a lot more advantages even. So for example, older recipients, if you're older and could benefit from a liver transplant, it's very difficult to be on the waiting list because the likelihood of being able to survive to the period where you get to the top of the list is very low. But we know that these patients can have good results, and we've transplanted individuals that are almost close to 80. Last year we did 2 individuals that were into their late 70s and had good outcomes. Other cases such as repeat liver transplants or a simultaneous liver and kidney transplant, all of those are potential options with a living donor. And so that's what we've been working on, as I talked about before, is to educate. We want to educate payers, we want to educate physicians, and mostly we want to educate patients and the people who are looking after their family members about what living donor liver transplant is about, what are the risks, what are the benefits, how you can go about finding a living donor suitable. And so we have lots of resources available for patients. We have educational brochures, videos that teach patients about what living donor liver transplant is about. We have something called the Champion Program, which essentially helps patients to help themselves. It teaches them how to go about finding a suitable living donor, how to extend their reach to what we call their extended network, not just their family, but their community, their church members, the people who they work with, and even further beyond to their extended network, to people that they may have met on or knew many years ago, or in contact with on social media, but may not be seeing on a regular basis. Those are all people that could potentially be suitable donors for them and would be willing to be donors for them. And that's why we've had this campaign on a national basis. You may have seen it either in the ad form or that's called the Get Out of Line campaign. And that's just to educate people around the country that this is a possible option that they could at least consider. They may not want to pursue it, but at least they can consider it and discuss it with their family and discuss it with their friends. So we think that it's time to think about liver transplant quite differently in the setting of a successful living donor liver transplant. Now remember, all of the rules that we have in place for allocation of livers, the MELD score, and all of those were really set up because we had this unique situation of a limited resource in a lot of people, i.e. the situation where you have 8,000 transplants but 14,000 people that need them. So you have to have a way to allocate these organs in an orderly fashion in that scenario, and there has to be a system of priority, and the system that we have at the present time with MELD score is a very good system. It prioritizes the people that need it the most. But if you think about it, if you have a living donor available, those situations and those rules don't necessarily apply, because now you're not trying to allocate a scarce resource. You have the situation not of 8,000 livers, 14,000 recipients. You have the situation of one donor and one recipient, one person who wants to donate to help one other individual. And therefore, the rules don't necessarily have to be the same as those for allocation. And really, we should think about living donor liver transplant based on its ability to provide a survival advantage to a patient. That's how we evaluate any medical therapy that we have, whether it's a new drug. How do you evaluate if a new drug is good or not, or if it should be approved? Well, is it better than what the current standard of care is, what the best available other option is for the patient? And if it is, then it's a good therapy. And maybe then that's the way we should be thinking about live donor liver transplant. Not as something that's the last resort, but rather the first resort that we should think about for patients if it's going to help them. And so for us, our criteria for choosing patients has become very simple. All we look for is, are they going to have a significant survival benefit with a liver transplant over best available therapy out there, whether it's another different type of surgery or some medication or chemo or whatever. Does the liver transplant give them a better result? And if it does, and they have a suitable, willing living donor, then that to us is an indication of proceeding with the liver transplant. And that's what we'd like to do. We think in the future it's possible to eliminate the wait list. That if with judicious use of things such as living donor, no patient should ever have to sit on a waiting list. And if you're a patient waiting on a liver transplant waiting list, you know what that means, how awful that is, how you're essentially living day to day wondering whether that call is going to come in tomorrow or tonight to get called in for a transplant, or if you're ever going to get that call. And that's a terrible way to live. And we think that doesn't have to be, that we can eliminate that wait list. But to do it, we have to educate. We have to educate the physicians, we have to educate the payers, and most importantly, we have to educate patients and their families that this is a possible option that we should consider. So that's where I'd want to leave you at. And as I said, I think this is just something you have to discuss amongst yourselves, amongst your families, amongst your friends, and at programs to see if this is something that's right for you. So maybe I'll stop there, and I think we can hear from Tony, and then we can open it up for questions.
Okay, thank you. First of all, let me thank the American Liver Foundation for inviting me here to discuss this very important topic. I received a living-related transplant in June of 1999. So, and it's really surreal to think about it, but in approximately 3 months, I will have survived 20 years with my daughter's liver. My daughter Elise is a real hero of this story. I call my journey, by the way, a science fiction love story, based on the fact that the tremendous bond between myself and my daughter Elise, and the groundbreaking, like really otherworldly, medical talent and procedure that resulted in me receiving the gift of life. I was originally diagnosed with cirrhosis back in 1998 due to progressive hepatitis C disease. This may have been, hanging out in my body for approximately 35, 40 years, possibly in the 1970s. After my diagnosis, I received a liver biopsy, which confirmed the cirrhosis. And then by 1999, it had really activated to the point I took some CAT scans, and I had that situation, that experience that you do not want to have, where you call the doctor's office, for a result of your scan, and no one will talk to you on the phone. So that really, gave a clear message that something was wrong. And sure enough, in March of 1999, I was told that there was a tumor approximately 4 centimeters, which looked, in quotes, suspicious. Now, that suspicious tumor turned out to be liver cancer. I was then sent to a very one of the foremost cancer centers in New York City, and I was told that basically I should wrap up my affairs, that there was nothing that could be done, that this would definitely take my life, in combination with the fact that apparently I had also been exposed to hepatitis C. My wife and I, Edie, we were both devastated upon hearing that news. However, that devastation lasted about a day, and I woke up the next day with renewed confidence that there could be some answers. My journey then led me to Mount Sinai Hospital, which really treats patients with dignity and respect. And I then met with the great Dr. Charles Miller and the outstanding and compassionate physician, Myron Schwartz. And we were actually given options. One option could be that the tumor, could be surgically removed, but since I had cirrhosis and they would have to also take surrounding tissue, my recovery was very, very questionable. Dr. Schwartz, indicated to me, look, you probably have about 3 months, to live, in so many words, because my platelets were dropping precipitously, and I would probably bleed to death at the end of that period. However, there was this new procedure, because don't forget, we're talking about 99 now. This was in 20 years ago. There's this new procedure called, they said, living-related, donor transplantation, and which would be ideal for me because I could technically be on a waiting list. But by the time my number was called, the cancer would have already metastasized. And one advantage I did have was that the tumor was localized. It was only in the liver at that point, but it was poised in such a way that it would probably spread. So we talked about this new procedure that really I think the first time it was done was in 1997 in the States. It had been done, I believe, in Japan before that. So this was our family's dilemma. Obviously this would be the way it could get a quality of life restored. But now, how do you go about? You don't just go on the street and put up a sign and ask people for how's your liver? We simply presented the dilemma and spoke to our family. And once we disclosed that I was very, very sick, my daughter Elise said something that will always stay with me in a very emotional way. She said, "Dad, you gave me life, and I want to give it back to you." And she had just had a baby in the beginning of April, and they were talking here, May, and she's 6-8 weeks in, and I certainly didn't want her to be my donor. However, nothing, would stop her from this mission. She was home on maternity leave, and she said, "Well, look, I'm not going back to work for 3 months anyway." So we presented this option, to Mount Sinai. She underwent an exhaustive evaluation. They checked everything because the worst possible outcome would be that even though I possibly could die, that something should happen to my daughter, a new mother. That would really, really be tragic. I mean, picture the family situation here. Here's my wife, possibly, in the midst of becoming a widow, and then her daughter is going to be on the table as well. And to further complicate the situation, I was really a hog about it because I would actually need her right lobe. And at that point, I don't believe there were any left lobe transplants right lobe transplants that had taken place in New York State, and the right lobe being approximately maybe 65% of her liver, and that's what I needed in order to survive. Needless to say, there was a lot of support, and I always tried to maintain a very positive attitude about this procedure. And I think really, when you look at for you patients out there, I believe it really is a question of 50%, positive attitude and prayer, and 50% science in order for it to be, totally successful. In any event, my daughter was approved, to be my donor. The surgery, was successful. I had about 6 months of very, very difficult, complications and side effects. I developed a problem with my bile duct. There was a blockage. I was hospitalized numerously, and then they, in fact, had to reoperate and do a bile duct repair. And that was in early 2000. That was really the trick. And once that was done, it seems that I had a totally return to a quality of life, to energy level, activity level. I'm pleased. Well, like I say, I'm pleased to be anywhere. I'm pleased to be vertical, obviously, but I'm just pleased to be able to do the things that I did. Prior to this process, I was able in 2015 to be enrolled in the with Harvoni, the miracle drug there, Harvoni treatment, and in a period of about 8 weeks, I actually cleared the virus. I second what Dr. Humar was stating about the benefits of the living donor transplant. Again, you don't have to be as sick. The liver is dedicated to you, so you can possibly avoid the transplant list. While I was hospitalized prior to being operated on, there were many roommates that I had that were fighting like crazy in order to maintain their status on the waiting list, but they passed away. So I think this is a real option. I don't believe you go into a room or to ask people to donate the liver, that you just lay out your story. And if people care about you enough, that they would, in fact, make this sacrifice, to you, then this is really a wonderful thing. I just want to say that I'm proud to be working and volunteering with the people of ALF. Also a member of Long Island Trio. I want to say God bless to all of the patients, to the fantastic physicians, the nurses, the transplant coordinators, and the donor families for all the fantastic work that is taking place. I want to thank you again.
Thank you, Tony. Okay, now we will answer some questions. We have about 10 minutes, so we'll answer as many as we can, but like I said, we will answer any questions we don't get to at a later time via email. I do want to remind you that we will not answer any personal patient questions, so please keep them general. If the liver regenerates, this is the first question for Dr. Humar. If the liver regenerates, can we grow livers to resolve these issues? Is this being investigated?
So people are looking at whether we're able to grow livers and generate organs in a test tube, so to speak. That's for all organs. But that technology is still, I think, many, many years away, and it's not likely to be a solution in the near future. People often ask if we can grow livers, then can a donor not just donate and then donate again at a later time once the liver regenerates? But unfortunately, that's not the case. Once you donate, you can really only be a donor once. The liver regenerates, yes, but essentially the portion of the liver that's left behind grows back in size. You don't actually grow back the part of the liver that you donated.
Thank you. The next question is, if someone is fit but they have multiple sclerosis and it's relapsing, are they eligible to be a donor?
Most likely not. Because especially if it's a relapsing type of thing, we would not want to put a donor through the additional risks and the rigors of the recovery period. Generally, we have a fairly strict guidelines as to who can be a donor, and that's really just to try to protect the safety of the donor. As I said, the paramount thing in this is to make sure that we can do this with the utmost level of safety. So we would not compromise and take donors that are unhealthy or have some other major medical problems.
Thank you. Okay, this question is for Dr. Humar and Tony, the second part. So the first part is for Dr. Humar. What are the side effects of immunosuppressants after surgery? Do patients develop any kidney bone issues with long-term use of steroids and immunosuppressants?
Yes, so very good question. There are unfortunately a lot of side effects associated with immunosuppression medications, and there are very many different immunosuppression medications, but they all have some side effects. Because remember, think about it, the anti-rejection medications work by suppressing the immune system. The immune system is what helps us fight infections, helps us fight certain types of tumors. So unfortunately, every patient who's on anti-rejection drugs is at higher risk for infection, is at higher risk to develop certain type of tumors. Beyond that, then there are other side effects associated with the medications, including that they can cause kidney failure, they can cause osteoporosis, bone fractures, etc. And so we try to minimize medications as much as possible in patients, and we're looking at ways to promote tolerance. So tolerance is the condition where we can do a transplant without the need for long-term anti-rejection medications. And we have such a protocol ongoing at the present time at our center, where we take cells from the donor prior to the transplant, and these are immune cells that tell your body essentially not to fight yourself. And so we give these cells into the recipient prior to the transplant with the hope that they'll send signals to the recipient that they shouldn't fight against the organ that's coming in. So this study is just underway. We've got about 10 patients enrolled in that, and we're just beginning the process of trying to see if we can remove those patients from long-term anti-rejection medication. Now, if that works, great. If it doesn't, we have other protocols that we're trying, but certainly we're looking at trying to investigate ways that we can do the transplant without the need for long-term anti-rejection medications.
Yes, in my own case, I am still on Prograf. I take 1 milligram twice per day. Subsequent to my liver transplant, I did develop high blood pressure, which I am on a number of pills, to manage that condition. I know that there was a concern also about, potentially prediabetes, in terms of, one of the side effects. Fortunately, I've kept my, my glucose, reading, pretty stable. I was also on Cellcept in terms of improving kidney function. For a number of years. Again, I was lucky to have, that actually removed, from my regimen about a year ago.
Thank you. Okay, this question is for us from students in a health class, actually. Is the liver the only organ you can donate while living?
No, there are a number of organs. In fact, the first organ to come from a living donor was the kidney, and that still represents the most commonly performed living donor type of transplant, because remember, we have 2 kidneys, and we can actually survive very well with just 1 kidney. So the most common live donor transplant is a kidney. But other organs have been done. The next most common is the liver, but lungs have been done from living donors. Pancreas transplants have been done from living donors. Even intestine transplants have been done from living donors. But the liver and the kidney represent the 2 most common.
Thank you. Do most major insurance companies cover living donor liver transplantation, since it's somewhat elective if the patient has a relatively low MELD score?
Yes, I think most insurance companies, if they cover the liver transplant, will generally cover a live donor transplant, and as long as the patient has indications for a transplant. And that doesn't necessarily have to be based on MELD score. We can transplant patients that have low MELD score, because we know that patients that have low MELD score, but if they have a number of other symptoms related to their liver disease, for example, if they're having to get ascites tapped on a regular basis, if they've had admissions to hospital on a numerous basis for bleeding or numerous infections, or if they're losing a lot of muscle, all of those are conditions that suggest a worse prognosis than their MELD score, and certainly those patients benefit from a transplant.
Right. Yeah. Also, let me add, back in '99, where this was really considered, either experimental or controversial, there was some resistance initially on the part of my insurance company, but doctors Miller and Schwartz were able to justify it, even while I was, actually, in the hospital, receiving the gift of life, and it was eventually approved.
Okay, with the LDLT program, are livers with hepatitis C being used for patients that do not have hepatitis C?
So not with a living donor, we've not done that, but certainly with deceased donors, we've started, and other programs have started using livers from hepatitis C positive donors into recipients that are negative, with the expectation that we would treat them with these agents that are very effective and get rid of the hepatitis C. But we have not done that yet for living donors. So potentially you could, with the current therapies, treat the donors for their hepatitis C and then transplant.
Thank you. This is a question from someone that works in the field, and they get questions about if a patient or a loved one has liver failure. When they mention transplant, they immediately say their doctor said they aren't a candidate. Are we giving false hope by saying go for an evaluation anyway?
So that's a good question. I mean, I think if someone has liver failure, they should see a liver specialist to determine if they're candidates for a liver transplant or not. I think there are a lot of misgivings, a lot of misinformation about liver transplant, and especially about living donor liver transplant. We hear many, many times from patients that they were told that they weren't candidates for a living donor transplant, and they were told they weren't candidates essentially because the program they were at didn't do live donor transplants, and so we encourage everyone to think about it and at least find out about it. And certainly they're welcome to call our center and get it. We have a very high acceptance rate in terms of patients that we would be willing to transplant with a living donor, and that's because we've got a comfort level with it and an experience level with it that other centers may not be willing to do with a living donor.
Thank you. Okay, we have time for a couple more questions. What is the average age of a living liver donor?
So we have a selection criteria. Our donors have to be between the ages of 18 on the young side and 55 on the upper side. But the average donor age for our center is about 36.
Okay.
Can you donate a liver to someone who has liver and colon cancer?
So we do have a protocol for patients who have colon cancer that's metastasized to the liver. That's a specific protocol to treat, and they have to fall within certain criteria. If they have a separate liver cancer that's not related to their colon cancer, but they have a colon cancer also, then we would generally require that they initially have treatment of their colon cancer and see how extensive it is, and depending on that, then we can decide if then they should have a liver transplant for their liver cancer.
Thank you. Okay, I think that's all the time we have for questions. As I said, we will answer these questions, the rest of them, via email. So thank you very much for your time, Dr. Humar and Tony. Thank you to UPMC for the support of this program, and thank you all for joining us today. We will be posting a recording of this webinar on our website, so you can view this again at a later date. With that, we'll bring the webinar to a close. Thank you all so much.
Thank you.
Thank you, Dr.